with IMA Tirupur. We Revati Medical Center, as every year we do more and more CMEs. This live webinar series, I hope, will throw lights by all our experts. As you all know, Dr. Muruganathan will be speaking to us on hypertension in diabetes patients, how to manage it. Likewise, we have other speakers like Dr. Mani. He will be speaking on Gliclazide cardiovascular safety, and Dr. Nagarajan, cardiologist of Revati Medical Center, will be speaking about diabetes and heart failure, and Dr. Magudeshwaran is a MD general physician, consultant general physician from Kangayam. He will be dealing and talking with diabetes management in CKD. I thank IMA Tirupur for having consented to conduct this webinar, and I'm sure Dr. Nazir will be joining in a few minutes, and Dr. Gunasegaran. Dr. Nazir is a senior physician, and he will be the moderator. So also Dr. Gunasegaran, who is the chief neurologist of Revati Medical Center, he will be moderating this session. And I wholeheartedly thank Dr. A.M. Palanisamy, President IMA Tirupur, Dr. Rajkumar, Secretary IMA Tirupur, and Dr. Ramesh, Treasurer IMA Tirupur. Over to moderator and Dr. Muruganathan, sir.
Ishwar, am I audible?
Yes, sir. Gunasegaran, sir. Yes, sir. Very much, sir.
Yeah, can I just talk for a minute?
Yes, sir. Proceed.
Okay. Good evening, everybody. So it will be a very nice session to hear from our giants like Dr. Muruganathan. Talking about diabetes and hypertension, the treatment is aimed towards preventing the target organ damage, predominantly the heart, brain, and the kidney. So combining a very good therapeutic approach can prevent all damage such as stroke, cardiac failure, or renal failure. In fact, we have been seeing a lot of cases of renal failure in Revati Hospital, strokes, and heart attacks because of poor control of diabetes and poor compliance of hypertensive treatment. I'm sure I will not be taking much of your time, and I directly ask Dr. Muruganathan to start off with this lecture. Thank you very much, Ishwarmurthy, for this fine opportunity. Thank you.
Dr. Ishwarmurthy, what about our members? Have they joined?
Can we ask Dr. Muruganathan to join the web?
No.
He's online.
No, I am. See, I am there.
Sir, Mithun is the he is the controlling everything, admin, sir. Mithun, how many doctors have joined? Can you share those things? Mithun?
7 doctors have joined, sir. I am Ranjit Kipka RBM, sir.
How many have joined?
Sir, 3, 4, 5, 6 doctors, sir.
Okay, and what about IMA president and secretary, and nobody has joined it?
Sir, I informed, sir. They are telling that we are soon we will log in, like that they told, sir. We can continue, sir. In between, they will log in, sir.
What about Nazir, moderator? I called him. He said he'll join in 3 minutes. He has not joined.
Yes, sir. Yes, sir. They are dealing with the laptops only, sir. Soon, 1 or 2 minutes, they will join, sir. We can continue, sir.
No.
Sir, Muruganathan, sir.
Yes, Guna. Tell me, Guna.
See, right now there is a Indian Academy of Neurology stroke. Louis Kaplan is talking from Harvard.
Okay.
So actually I sent to. So actually I'll just I've come inside. So I'm leaving that meeting.
Okay.
You can start off, or you can wait for some more time for others to join.
No, that's what I'm asking you. If you say start off, we can start, because right now there are only what I see is 11 only here. And
so because this being 8 o'clock, it should be finding it difficult for most of us to join. You have to accept that, like most of them are in active practice.
Yeah. I think the timing must be 9.
Yeah. But if you go a little later, it becomes, like it is little difficult.
Yeah, but
actually,
no, it's good for me because, Guna, I have back-to-back 3 webinars. I finished 2 webinars. One more webinar pending on 9 o'clock.
Actually, I've just come out of a webinar on Indian Academy of Neurology is conducting.
But Nagaraj, Nagaraj, if I talk and then Nagaraj, can you hear me? Nagaraj? I think Nagaraj is not able to unmute. Nagaraj?
I think the host has to unmute it.
No, Nagaraj is giving a talk, but not able to hear. Nagaraj,
Professor Sunil Narayan from JIPMER is presenting, and another from AIMS HOD is talking, along with the Harvard University.
In fact, Kuna, I inaugurated the Stroke Summit on 28th and 29th.
Unfortunately, we had so many things, one from Coimbatore, our Neurological Society, other from Tamil Nadu Academy. So we were not finding it much time to join many. Either you are here or here, same way epilepsy. We have epilepsy summits almost every Tuesday. So I'll just switch on and continue to see the patient, continue to see the slides.
Okay, so what do you suggest, Guna? Can we go ahead now? Nazir, if he joins, at least it's good. No, because
I think it is more important a senior physician like Nazir should join.
Yeah.
Because someone who's been treating a lot of diabetic patients of that area.
Yeah.
Probably with.
I'll call him now. I'll call him whether he is joining.
Yeah, somebody can call him on telephone.
Yeah. And IMA people also not here. Most of them. So do you have a attendee link separate and faculty link separate?
I don't know. I don't know that.
Ramesh is joining. ஆயிட்டீங்களா சார்? நீங்க வந்த உடனே தான் ஆரம்பிக்கணும், அதுக்காக தான் வெயிட் பண்றோம். ஓ தேங்க்யூ. I think Nazir is joining in 2 minutes. Okay. Ramesh has joined and I think
Ramesh, I think he's online.
Ramesh vandittaru sir.
Vandittaru. Ramesh
he's available.
Yes, very good. Good evening, Ramesh.
AMP join பண்றாரு sir. AMP will be joining in 1 minute sir.
Okay. So when Ramesh comes, it's like equal to 100 people have joined.
Sir, why this column? Sir, நீங்க தான் central council member equal to 100 members.
Ramesh பரவாயில்ல. Because Ramesh, Palnisami, Rajkumar 3 பேர் இப்பதான் அருள்ராஜ் வந்துட்டு போனார். ரமேஷ் அருள்ராஜ் தெரியுமா? அருள்ராஜ்
பரவாயில்ல சார்.
Past national president, he was here with me.
ஆமாங்க சார். இதுல பார்த்தோம், கொடைக்கானல்ல பார்த்தோம் நேர்ல.
அதான் அவர் இப்ப வந்துட்டு இப்ப எங்க கூட வந்துட்டு இப்பதான் போறாரு. நாளைக்கு எங்களுக்கு கோயம்புத்தூர்ல வந்து தமிழ்நாடு API மீட்டிங்.
சரிங்க.
தமிழிசை தான் இனாகரேட் பண்றாங்க. தமிழிசை சவுந்தரராஜன்.
சரி.
அதுக்காண்டி
she is a radiologist telling
sir. Just to inform you, we are being viewed live across India, sir.
That's great. That's good. But do you have any attendance from outside Tirupur?
Yes, sir. Doctors are logging in across from outside, sir. They are registering on the login pages. So we are live and they are awaiting for this.
Okay, very good. Now Rajkumar is joining.
நான் நிறைய குரூப்ல ஃபார்வர்ட் பண்ணேன் சார்.
Very good. In fact, நாங்க ஒரு டயபெட்டிக் மாஸ்டர் கிளாஸ் பண்றோம் ரமேஷ். ஈவினிங் 9 மணிக்கு மாஸ்டர் கிளாஸ் வெபினார் ஆன் டயபெட்டிஸ்.
சரி.
ராஜ்குமார் வந்துட்டாப்ல.
வெல்கம்
ராஜ்குமார்.
சார் நான் அந்த மெம்பர் இதுல போகாம அதுல போயிட்டேன்.
சரி. ரைட். பரவாயில்ல. நீங்க நான் நினைச்சேன் சிஎம் பாத்துட்டு வரீங்கன்னு நினைச்சேன்.
இல்லைங்க சார், அவரு தான் நம்மள இருந்து பார்க்கணும். அவர் 10 மணிக்கு தான் வருவாரு இருக்கு.
அதான் அருள்ராஜ் இந்த ரோட்ல போக சொல்லிட்டேன்.
ஆமாங்க சார், எல்லா ரோடும் பிளாக் பண்ணி வச்சிருக்காங்க சார் ரொம்ப.
சரி. நசீர் இப்ப ஜாயின் பண்றேனாரே, நசீர் ஜாயின் பண்ணனும்னா ஆரம்பிச்சிடலாம் ரமேஷ் இல்ல?
ஓகே சார்.
அவங்க மத்த மைக்கெல்லாம் அவரே மியூட் பண்ணுவார் இல்லையா? நம்ம பண்ண வேண்டியதில்லை.
ஏஎன்பி வந்துட்டாரா?
மகுடேஸ்வரன் சார், குட் ஈவினிங். டாக்டர் ராஜ்குமார் திருப்பூர்.
குட் ஈவினிங் சார். குட் ஈவினிங் ராஜ்குமார்.
இவருங்க சார்,
வந்துட்டாரா?
டாக்டர் கே மணி.
வந்துட்டார்.
குட் ஈவினிங்.
இருக்காரு எங்க ஹாஸ்பிடல், அவர்லாம் இருக்காரு. அவர் இருக்காரு, மணி இருக்காரு.
நான் சொன்ன ராஜ்குமார்
சார்,
ரமேஷ் வந்தா 100 பேர் வந்த மாதிரி, ராஜ்குமார் வந்தா 1000 பேர் வந்த மாதிரி. யா ரமேஷ், கரெக்டா?
நீங்க வந்தா லட்சம் சார்.
ஐயோ,
கவுண்டர்ல யோசிக்கிறதுக்குள்ள அடிச்சா பாத்தீங்களா?
சார் லிங்க் கிடைச்சதா சார்?
நசீர் ஜாயின் பண்றேன்னாரு.
உங்களுக்கு எல்லாரும் வெயிட்டிங் சார். முருகன் டாக்டர் நசீர் எல்லாரும் வெயிட்டிங். வாங்க.
எங்க தலைவரை காணோம்.
நீங்க ஈஸ்வரமூர்த்தி.
எஸ் சார்.
நீங்க சொல்லுங்க, யாரெல்லாம் இன்னைக்கு அட்டெண்ட் பண்றாங்களோ
சரிங்க சார்,
அவங்களுக்கெல்லாம் வீட்டுல வந்து ஸ்விக்கி சாப்பாடு போயிடும். இன்னைக்கு அட்டெண்ட் பண்றவங்களுக்கெல்லாம் ஸ்விக்கி சாப்பாடு அவங்க சொல்ற இடத்துல இருந்து. ரமேஷ்க்கு வந்து ஒரு தலப்பா கட்டி பிரியாணி பிடிச்சதுன்னா அங்கிருந்தே போயிடும்.
பண்ணிடலாம் சார். இது என்ன சார் இது பண்ண முடியாம?
இல்ல, அதை பண்ண முடியாம இல்ல, இது ஒரு இது. யாரெல்லாம் இன்னைக்கு இருக்காங்களோ அவங்க வீட்டுல ராஜ்குமார் பல்லடத்துக்கு ஸ்விக்கி இல்லைன்னா கூட ஒரு ஆளை வச்சு அனுப்பிச்சு விடலாம். என்ன ராஜ்குமார்?
கொடுத்து சாப்பிட்டுக்கோங்க சார்.
Around 150 doctors have joined from outside, sir.
Super. I think when Nazir comes, we'll start. Bugari, அப்பா எங்கப்பா?
ஹலோ,
புகாரின்னு வருது. நசீர் பழனிசாமி வந்துட்டாரு.
ஹலோ சார். சார் ஆடிபிளா? ஹலோ,
Audible, sir.
ஓகே ஃபைன், தேங்க் யூ.
நசீர் ஆரம்பிச்சிட்டீங்களா?
இல்ல, நாகராஜன் தான் வந்திருக்காரு, நசீர் வரல.
இல்ல, வந்துட்டாரு. நசீர் பாருங்க, கலர்ஃபுல் ஷர்ட் போட்டு வந்திருக்காரு.
குட் ஈவினிங் சார். நசீர் சார், ராஜ்குமார் சார்.
குட் ஈவினிங் சார்.
ஏஎம்பி வந்துட்டாரு. ஏஎம்பி சார்.
ஓகே.
எஸ் சார்.
ஐ திங்க் எல்லாரும் வந்துட்டாங்க. இப்ப ஆரம்பிச்சிடலாம். நீங்க இப்போ எப்படி ப்ளீஸ் ஆரம்பிச்சிடலாமா நசீர்?
சார் எல்லாருக்கும் வணக்கம். என்னுடைய தாமதத்துக்கு கொஞ்சம் வருத்தம் தெரிவிச்சுக்கிறேன். குணா அண்ணன் முருகநாதன் அவர்களுக்கு என்னுடைய மாலை இனிய வாழ்த்துக்கள். நம்ம ஐஎம்ஏ தலைவர், செயலாளர், அப்புறம் எல்லாம் நம்ம பொருளாளர் மற்றும் வந்து எல்லாரும் இன்னைக்கு பேசக்கூடிய அவங்க எல்லாத்துக்குமே என்னுடைய வணக்கத்தை நான் சொல்லிக்கிறேன்.
குட் ஈவினிங் சார். குட் ஈவினிங் சார். குட் ஈவினிங் ஆல் சார்.
Okay, Nazir, we can start. We are waiting for your moderation.
Okay sir.
இன்ட்ரோடக்ஷன் முடிச்சிட்டேன், போதும்.
With pleasure. Okay, அதனால தான் நான் குணாவை கூட உள்ள எடுத்துக்கிட்டேன். என்னுடைய ஸ்டாண்ட் பை
நான் முடிச்சேன்.
Thank you குணா.
நான் எல்லாம் முடிச்சிட்டேன், எல்லாம் ரைட். ஓகே,
வெரி குட்.
ஸ்டார்ட். முருகநாதன் சார் ஆரம்பிங்க.
ஏஎம்பி சார்.
என்ன ரொம்ப நேரம் ஆயிடுச்சு.
Okay. Yeah. Can I start? Palanisamy, Rajkumar, Ramesh?
Yes sir.
சார் பண்ணலாம் சார்.
Okay. This is the slice screen.
மத்த ஆடியோ எல்லாம் மியூட் பண்ணலாம், வீடியோ முடியும் இதெல்லாம்.
Okay. So I'll start this screen sharing. Slide தெரியுதுங்களா?
எஸ் சார்.
தெரியுங்க சார்.
தெரியுங்க சார்.
Okay. Full screen தெரியுதா இப்போ? Okay, right. Thank you, dear President Dr. Palanisamy, Secretary Rajkumar, Treasurer Ramesh, my beloved brother Nazir and Gunasegaran, the host of this meeting, Dr. Iswaramurthy, Nagaraj, Mani, Magadeshwaran. In fact, this program, when Iswaramurthy asked me, I said I'll join, but I never thought he will ask me to be a speaker. Only today morning I knew that I am going to be the speaker, first speaker also, because I have 3-4 webinars today. So I'll have to finish fast and then leave the responsibility to Nazir and Nagaraj if there is any question. So my today's agenda will be a prevalence of the hypertension, diabetes, bird's eye view, pathogenesis and impact, the points to ponder, and then goals and therapeutic choices, a touch, and then carry back messages to implement. So with this, I'll start. How common is this diabetic hypertension? Hypertension is twice as common in diabetes. If you take a normal person, the diabetic patients develop twice compared to normal person hypertension. The other way, if a hypertension patient has got a chance of developing 2.5 times more than the normal person. So what is the teaching? Any hypertension, look for diabetes. Any diabetes, look for hypertension. And 75% of the cardiovascular disease in diabetes is due to hypertension. But unfortunately, only 10% of the people with diabetic hypertension are under control. So this is a paper which says prevalence of concomitant hypertension and diabetes in India is 21%. This is a twin epidemic study. What are the causes, the pathogenesis of hypertension in diabetes mellitus? In type 1, it is due to nephropathy. Sometimes now recently they said metabolic cause also can cause hypertension in a diabetic patient, diabetic type 1 diabetes. Then type 2, it is due to nephropathy because of the ROS hyperactivity. Insulin resistance again due to ROS hyperactivity and inflammation. Volume expansion because of the aldosterone, sodium dysregulation and vascular changes, endothelial dysfunction and compliance reduction. So these are the causes of hypertension in diabetes. One in type 1, it's nephropathy. Type 2, these are the causes. If you see, it can be combined lifestyle factors, diet and inactivity, stress and smoking, genetic factors, malnutrition in early life, drugs and hormones. All these 4 things produces insulin resistance, and that insulin resistance leads to endothelial dysfunction, insulin-induced nitric oxide generation also reduced, and contractility of the vascular muscle, and peripheral vascular resistance and hypertension. The other way, it also insulin resistance increases the aldosterone, and then it causes hypertension. One more way is the unopposed sympathetic stimulation, which also causes abnormal vascular development and malnutrition in early life. All this causes vascular resistance and hypertension. So this is in short pathogenesis. So it is both the environmental, genetic causes for hypertension in diabetes. Okay, now we said about hypertension, diabetes. What is the impact of the hypertension on diabetes, or what is the impact on diabetes on hypertension? If you see, I already told you the genes, insulin resistance, dyslipidemia and obesity can cause both diabetes and hypertension. The risk factors for diabetes and hypertension are common, and this leads to atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, arterial remodeling. What is the result? It causes macrovascular disease as well as microvascular disease. So this diabetic hypertension causes macro and microvascular disease, which leads to cardiovascular disease. Hypertension, diabetes is a dangerous duo. And if you see the impact I told you, hypertension substantially increases the risk of both macrovascular and microvascular complications. CV risk by 3-fold, and diabetic hypertension 6-fold greater risk of developing end-stage renal disease when compared to non-diabetic hypertension. Diabetes also increases the risk of coronary events 4-fold in women, especially after menopause. So if somebody is after menopause, if they have diabetes, their chance of developing hypertension and the coronary events are more. Hypertension is associated with 57% increase in all-cause mortality in diabetic patients. And these are the complications attributable to stroke. Guna is there. He always say diabetic hypertension, stroke is 75%. Renal disease, 50%. I think Magadeswar is going to talk about this. CAD, our friend Nagaraj is going to talk, 35%. Retinopathy, 35%. Amputations, 35%. So 60 to 80% of diabetics will die of cardiovascular, particularly stroke. Okay, what are the benefits of various interventions of CV events? When you lower HbA1c by 1%, you can reduce 2.9 cardiovascular events. If you reduce the LDL cholesterol by 1 millimole, you can reduce 8.2 CV events in 200 patients. Whereas if you reduce systolic blood pressure by 4 millimeter, you can reduce 12.5 cardiovascular events. So what is the importance? So if suppose somebody has got diabetes and hypertension, if you reduce the hypertension by 4 millimeter, you get 12.5 reduction of the cardiovascular events. So that is why we need more hypertensionologists. All over India, all over the places, we have diabetologists. But unfortunately, we have very few hypertensionologists, very few people who are interested in hypertension. That is the idea of now promoting hypertension focus now. What are the special characteristics of hypertension in diabetes? If you see, the lack of nocturnal dipping in arterial blood pressure, both in type 2 and type 2 diabetes. I'll come to you what is nocturnal dipping, lack of nocturnal dipping. The lack of nocturnal dipping associated with increased risk of stroke and myocardial infarction. So nighttime BP control becomes especially important in diabetics. I'll show you what it is. The ambulatory blood pressure monitoring is considered as the gold standard for measuring BP, especially in diabetes. It provides valuable diagnostic information in clinic and home BP monitoring systems are incapable of measuring BP variability and more accurate estimation of dipper status and morning surge in blood pressure. So the ABPM and diabetes, where all the ambulatory blood pressure monitoring is useful. My suggestion, my advice to all of you who are watching, please at least take one ABPM reading for all your diabetic hypertension patients, because that will give you a lot of information. The ABPM in diabetes is helpful in detecting autonomic alterations in autonomic control by absence of nocturnal BP fall. Normally, the BP should be reduced in the normal person. Whereas in the diabetic hypertension, the BP is high in the night time. Postprandial hypotension, 24 hours heart variability. See, in the Indian heart study we did, what does it say? Normally, any Western countries, the heart rate in the night time is less. Whereas in India, we saw diabetic heart patient, the heart rate is more, average 83. Similarly, 24 hours VB variability also more in the diabetes, and the response to treatment we can find out with the ABPM. By giving the ABPM, taking the ABPM, we can see whether the patient responds to the treatment. This is the normal ABPM. So anybody who wants to do ABPM, please consult me. I will give you ABPM so that you can do one time at least for your patients ABPM. So what is ABPM? Ambulatory blood pressure monitoring. What we do, you tie the BP apparatus cuff for the patient. 24 hours it records the BP. Especially the night time we need the BP. So this is the nocturnal dip. Normally the BP is dipping in the normal. Whereas in hypertension it is not dipping, it is more. And this is the normal early morning surge. As soon as the patient gets up, the BP goes up. So this is called nocturnal dip and this is the early morning surge. Both are exaggerated in hypertension. That's what we can find out in the ABPM. So this is a normal ABPM where you see nicely night drip and this is the early morning surge. I'll show you another picture where you can see this is a normal dipping and this is the 10% dipping from day BP. And this is the morning surge. Instead of normal surge, it is an exaggerated surge. That is the culprit for producing CVA and CVD. And this is another recording where they have a hypertension during night time. This is nocturnal hypertension and this is stage 2 hypertension. So in diabetic and BP variability, overall BP variability in the diabetes hypertension is more. Autonomic disturbance, arterial stiffness also contribute. Increased 24-hour BP variability predicts coronary heart disease. Nighttime systolic BP is independent risk factor of CAD, and visit-to-visit variability in BP was significantly associated with all-cause mortality independent of mean BP in patients with type 2 diabetes. So this patient, every time when you come to visit clinic, the variability is there. One time it will be 140, 90, the other time 150, 100, like that. So visit-to-visit BP variability. Iswaramurthy, can you mute please? Iswaramurthy.
Yes, sir. Yes, sir. I'm here, sir.
Please mute. Please mute your phone.
Yes, sir.
Okay, please. Okay, now excessive salt sensitivity and increased extracellular volume. The BP of diabetic patients are more sensitive to salt intake. So salt restriction is very, very important in a diabetic patients because they are very sensitive. Now, coming to diabetic hypertension, isolated systolic hypertension is also usually seen in diabetes, and that is the culprit for micro and macrovascular disease. And what guidelines suggest on BP targets? You see, now every time, there are so many guidelines have come. ACC guidelines in 2017 and 2018 European Society guidelines. Now in 2020, we have got the international hypertension guidelines. So these guidelines, what is the target for the hypertension in the diabetes? 130/80 according to ACC. If you see Indian guidelines, where I am also one of the author for it, it is diabetes 140/90. And then what is ADA? American Diabetic Association says 140/90. In a pregnant patient, it is 135/85, and the goal is less than 130/80. So these are the all the 4 guidelines. These European guidelines 140/90, ACC guidelines 130/80, the international hypertension guidelines is 130/85. Forget about all this target. What is the goal we must attain in a hypertensive diabetic patient is 130/80. So as far as possible, you must try to bring the blood pressure level 130/80. So you must always individualize target rather than a blanket advice. It depends on the age, life expectancy, previous associated comorbidities, overall treatment burden, hypotension, drug side effects, patient's attitude and support system. The lowest BP which the patient can tolerate without partial hypertension is the ideal BP, without compromising on critical vascular beds as well as the quality of life. So individualize the target according to the target organ damage, according to the comorbidities, you can reduce the heart rate. Target the blood pressure. In high normal blood pressure, more aggressive lifestyle measures. While blood pressure of more than 140/90, you do pharmacotherapy. So any patient comes to you, if the blood pressure is around 140/90, it is like high normal. Advise them intense lifestyle modification. Ask them to do exercise. Ask them to control their diet. Ask them to stop smoking. So this is a non-pharmacological treatment. Weight loss, if he is obese, you can reduce the weight loss. DASH diet, the dietary approach to stop hypertension. Very important. None of us follow. What do you mean by DASH diet? You should give 3 to 4 servings of the vegetables and fruits. That only will reduce the BP, sodium reduction, and also increase physical activity. You should not allow them to take diet in front of television. That is very important, because most of us take food in front of TV. So in those days, the TV is always bulge, and we patients are thin. Now the TV is thin. The patient who sits in front of TV is becoming bulge. So that is the difference between last decade and here. So these are the therapeutic lifestyle component. If your physical activity can reduce 4 to 9, the DASH plan can reduce to 8 to 14, and dietary restriction 2 to 8, and weight loss per kilo you can reduce up to 5 to 20 millimeters. So non-pharmacological treatment. Also, the strategy is proper blood sugar control, achieve the target level, early detection of both diabetes and hypertension, prevents complications and manage them as well as delay their progress. So the key message is identify hypertension early, do screening. Whenever somebody comes to you for any problem, whether toothache or a little finger injury, check the blood pressure. If the blood pressure is more, advise them proper BP control. The hypertensive patient, look for diabetes. If somebody comes with diabetes, look for hypertension. Okay, and you can prevent complications, multiple drug therapy, and especially diabetic patients, you must start them on statin therapy. Diabetic patients above 40 years, statin is very important. And what are the anti-hypertensive drugs you have? You have all the ACE inhibitor, ARB, non-DHP, the diuretics, and CCBs. So we'll come to one by one. What is the ideal BP anti-hypertensive drug? It should reduce the BP, long-term CV renal protection. It should be metabolically neutral. It should not produce dyslipidemia. Should not worsen coexisting medical condition. Compatibly with other drugs, well tolerated and cost effective, because you have to give lifelong, so it should be cost effective. Then hypertension, why RAS, renin-angiotensin system inhibitor, why it is top choice? Because in the nephropathy, it can reduce the RAS activity, it can reduce insulin resistance, and it can also reduce volume expansion, and it also improves the endothelial function. So RAS is the ideal drug. It also reduces BP with minimal side effects. They have no adverse effect and may reduce blood glucose concentration by insulin sensitivity. It reduces albuminuria, and it also reduces retinopathy. It is a renal protection and neural protection, a unique CV benefit, reverse LVH and cardiac protection. So ACE is very important, but ACE and ARB both are actually okay. So if somebody cannot tolerate ACE, you can give ARB. And telmisartan is a good drug because It has got bifunctional ARB. It also has PPR gamma pathway and angiotensin 2 pathway. In the angiotensin 2 pathway, it reduces AT1, it blocks the AT1 receptor blocker, and PPR pathway, it reduces insulin resistance and dyslipidemia. So ideal drug is a telmisartan in diabetic hypertension. What about beta blocker? Beta blocker sometimes we use, produces, masks the hypoglycemia, prolonged hypoglycemia, worsening of hyperglycemia, less protection for nephropathy, and increased insulin resistance. So the carvedilol is the only drug which has got insulin sensitivity. So whenever somebody need to be given in a diabetic patient, you have to give carvedilol as the beta blocker. We cannot stop beta blocker because withholding beta blocker in diabetes with CAD doubles mortality risk. So in a person with diabetes, if he has got coronary angio, Nagaraj is true to give beta blocker. The ideal beta blocker is carvedilol. Always you can use carvedilol or a newer beta blockers like bisoprolol or nebivolol. And these are the methods by which beta blockers are very good. It can reduce ventricular arrhythmia. It can also helps in the reduction of the blood pressure, especially night times, and sympathetic activity. Then diuretics. What is a diuretic? In the isolated systolic hypertension, diuretics is very important in elderly patient. Low dose combined rather than increase in targets are achieved. It is best combined with ACE and ARB. It normally you should avoid with a combination with beta blocker because it is a diabetogenic. Avoid in the HNK, the CTD. If chlorthalidone is a good drug, a diuretic. If creatinine is less than 2, chlorthalidone. If the creatinine is more, give loop diuretic. Indapamide is also preferable. And then in some cases, the resistant hypertension, we give spironolactone. The CCBs, the best add-on to ACE-ARB, long-acting, not useful in proteinuria, whereas non-DHP may be useful in proteinuria. Other classes, including alpha blocker, may be used under specific conditions such as symptoms of benign prostatic hypertrophy. A word about SGLT. Now, I think a lot of people talk about SGLT, and my friend Nagaraj is going to talk about diabetic heart failure. So now the SGLT is indicated even in a heart failure without diabetes. So popular now. The recent DAPA heart failure study proves very recently, only 1 month back, it has come. SGLT is a good drug. Now, SGLT is supposed to be now cardiovascular drug rather than a diabetic drug. A novel anti-diabetic drug with anti-hypertensive properties, canagliflozin, dapagliflozin, and empagliflozin all have BP reducing properties. The mechanisms are diuresis, nephron remodeling, reduce arterial stiffness, and weight loss. Reducing the dose of diuretics or other anti-hypertensive drugs is essential. This class of drugs is effective in patients with high glucose, BP, and weight. So nowadays, SGLT now is the molecule of the week, molecule of the year now. So ADA guidelines, you know what they say, the same thing what I said. Then this is the combination therapy. European guidelines says any blood pressure, even at the first beginning, don't give single drug, give combination. Combination therapy is now recognized as the most effective initial treatment strategy in most patients. Common denominator to all hypertension guidelines, initiate the drug treatment with comorbidity combination therapy, not as a monotherapy. And this is another recommended protocol which we published in the International Hypertension Journal. I was one of the authors for this, along with the other international authors. We also recommended simplified protocol to reduce hypertension. I already showed you the picture, how drugs act. ACE-ARB acts here. The calcium channel blocker, reducing the intracellular calcium. And this is the carvedilol beta blocker. This is statin. And this is the diuretics, naldactone. So these are the 5 drugs which acts and then gets the optimal BP. Now, the other effects, whenever you give any drug, it should not affect the glucose control. The ACE and ARB is ideal because dysglycemia as well as dyslipidemia is reduced. Whereas in diuretics, it is more, especially people with the gout, if you give diuretic, it is more. So you have to choose the correct drug. In uremia and the uric acid, you try to give ARB losartan. Beta blocker also increases lipids and the glycemia. So this is the algorithm. which I've already said. So you have to see if there is a nephropathy, start with AS and ARB, and then add-on drug will be CCB. So ideal combination is calcium channel blocker and ARB. And what are the difficulties in managing hypertension? Isolated systolic hypertension, polypharmacy must be there, glycemic control, and then renal jeopardy will be there. So you must always use this. And another thing is depression. Depression is more common in diabetes. So adherence is lacking, and clinicians' inertia is a big problem. And in the trends in hypertension and diabetes in India, if you see, 81% uncontrolled and 76% of diastolic is uncontrolled. Only 27.3% of the patients, both SBB and DBB, under control in India. So strategies: educate patients, screen for depression, ask about adherence. Please promote home blood pressure monitoring. We all promote home blood sugar monitoring. Please promote home blood pressure monitoring, and new ways of treating insulin resistance hold hope for countering both consequences and concomitant cardiovascular risk. Takeaways: huge population is there. Keep looking for hypertension and DM in hypertension. Achieve the targets. The newer, lower thresholds that diagnose and treat hypertension is less than 130/80, and then detect early in the pre-diabetic state, pre-hypertension stage. Interventions will prevent future DM and hypertension complications. So diabetes is a growing problem. Hypertension is also a growing problem. Hypertension and diabetes are dying problem. Hypertension is preventable. So never ever give up. You always would follow up. Control over diet, regular exercise, time to relax, does the right toil in discharge of his duties, observes proper hours of sleep and awakening, and is balanced in his actions and reactions, emotions and reasons, duties and rewards, conquers disease. So ladies and gentlemen, learning is beginning of health, learning is beginning of wealth, learning is beginning of spirituality. Thank you, Dr. Nazir and Gunasegaran. Now over to you. If there's any question, I can answer now. Otherwise, I will request Dr. Nazir and Dr. Gunasegaran and Dr. Nagaraj to answer the questions, because I will have to leave for another webinar. Thank you very much for the opportunity. Thanks IMA President, Secretary and Treasurer, all our members outside the country, outside the state. Thank you.
Hello.
Yes.
Sir, I think it was quite a lucid one. And I think diabetes and hypertension are two terrorists of mankind. So keep them beyond the gate. I think that will be the best thing you can do. I think you can go on to the next lecture. Nazir, you have anything to add?
No, proceed. We can go. Next speaker.
Thank you, Nazir. Thank you, Guna.
Thank you, sir.
Please permit me to leave.
Welcome, sir. It's a pleasure.
Permit me to leave. Thank you.
It's a pleasure listening. Last Dr. Mani to talk about supposed to be in the next.
Yes, sir.
Welcome, Mani.
Sir, good evening, sir.
Start away. You can go ahead. You can mute all other mics.
So once again, good evening to all members of Tripura IMA and the team IPCA for giving me this wonderful opportunity. So without wasting much of time, today I'm going to talk about the cardiovascular safety of Gliclazide. So as we all know, diabetes is a growing problem. The 2017 census, which shows the current diabetic patients around 424 million, which almost becomes 1.5 times by 2045. And Southeast Asia region itself contributes to 82 million, and this becomes almost double by 2045. So you can imagine how big the problem is. So diabetes is a major risk factor for both the macro and microvascular complications. The macrovascular complications include coronary artery disease, cardiac failure, peripheral artery disease, and stroke. And microvascular complications like retinopathy, nephropathy, and neuropathy. So diabetes is with increased cardiovascular disease risk, like hypertension. Compared to people with without diabetes, people with diabetes have increased magnitude of peripheral arterial disease, heart failure, angina, stroke, and other coronary artery and cerebral vascular diseases. So what is the pathway for cardiovascular disease development in diabetes? The main thing is the visceral obesity and associated with a genetic factor and environmental factors. This initial pathway is the insulin resistance leading to hyperinsulinemia. This in turn leads to endothelial dysfunction and inflammation, and both which again increase the insulin resistance. This insulin resistance leads to glucose intolerance, dyslipidemia, and abnormal hemostasis, and endothelial dysfunction also leading to hyperhomocystinemia and microalbuminuria. All this finally culminating in cardiovascular disease. So increased HbA1c is associated with almost 10 to 30% increase in risk of cardiovascular disease. For every 1% increase in HbA1c, the risk of stroke, coronary disease, and mortality is increased by almost 10% to 30%. So coming to the management of diabetes, this is a study which shows the benefit of glycemic control. So for each 1% reduction in HbA1c, the all-cause mortality is reduced by almost 21%. The risk of stroke, both fatal and non-fatal, gets reduced by 12%. And the risk of myocardial infarction reduced by 14%. The risk of heart failure from diabetes reduces by 16%. The microvascular complications like retinopathy, nephropathy reduced by 37%. And the risk of amputation by 43%. The all-cause mortality reduced by 21% for each 1% reduction in HbA1c. So in this graph, we see the hazard ratio. For each 1% reduction in HbA1c, there is a 14% reduction in the fatal and non-fatal MI and 12% decrease in the fatal and non-fatal stroke. So cardiovascular safety is essential for the anti-diabetic drugs. Why? Because the older drugs like first generation sulphonylureas like tolbutamide was discontinued because of increased cardiovascular mortality. Later on, Gliclazide and rosiglitazone were all associated with increased cardiovascular mortality, and hence the FDA has banned those drugs. So in 2008 and 2012, the FDA and EMA have required that CV safety is must, and the CVOT outcome must be performed for all diabetic drugs. So what is the role of glyclazide in diabetes management? So this is the picture which shows how the sulphonylureas act. So the common first generation sulphonylurea and most of the second generation, except for glyclazide, they mostly bind to the sulphonylurea 1 receptor, and thereby inhibiting this potassium channel, ATP dependent potassium channel. This, by inhibiting this, there is a calcium influx, and this causes the exocytosis and insulin release. Apart from that, the other other than glycoside, the sulphonylureas also bind to sulphonylurea 2A receptor on the heart. And why this I am saying is, this by binding to 2A, this inhibits the ischemic preconditioning. So what is ischemic preconditioning? I will come to it later. But however, glyclazide acts in a different way. The glyclazide binds only to the sulphonylurea 1 receptor. It doesn't bind to the 2A receptor. That its affinity towards the 2A is very, very low. So this slide shows the affinity of glyclazide and other sulphonylureas. So glyclazide binds only to the sulphonylurea 1 receptor, whereas glimepiride, glibenclamide binds to 2A and 2B. So 2A and 2B is present in the cardiac and vascular smooth muscles. So this selective binding of glyclazide to sulphonylurea 1 receptor explains why it has less cardiovascular side effects. So again, another table which shows the glyclazide binds to sulphonylurea 1 receptor with almost 800,000 times compared to heart, which is only 50 times. So the ratio is around 16,000 compared to glibenclamide and glimepiride, whose selectivity is very low. So this is another graph which shows the HbA1c reduction with different dosage of glyclazide. With HbA1c around 7 to 8%, the reduction with glyclazide comes around 1.03%. And at 8 to 9% of HbA1c, the glyclazide with glyclazide treatment reduction is 1.55%. And with 9 to 10%, the reduction comes around 2.35. And if the HbA1c is more than 10%, treatment with glyclazide reduces the HbA1c by 3.76%. That is more the HbA1c, the greater the reduction. So what are the cardiovascular effects of glycoside? As I already said, the first generation sulphonylureas prevent the cardioprotection induced by ischemia by interacting with cardiac potassium ATP channels, whereas the second generation sulphonylurea, they have less affinity for the cardiac sulphonylurea receptor. So what is ischemic preconditioning? Ischemic preconditioning is the repeated and brief occlusion of the same vessel. Preconditions the myocardium such that the subsequent prolonged and repeated occlusion leads to a smaller infarct. That is, with each and every time the heart suffers from ischemia, with ischemic preconditioning, the heart is able to tolerate it much better. Without ischemic preconditioning, the prolonged occlusion of coronary artery leads to myocardial infarction. So sulphonylurea other than glimepiride and glyclazide abolish ischemic preconditioning, resulting in large infarct size. This is because the glyclazide and to a lesser extent glimepiride, they do not bind to a sulphonylurea 2A receptor. And this helps in preserving the ischemic preconditioning. So this graph shows the cardiovascular safety profile of glyclazide. So this is a hazard ratio. So hazard ratio of 1 below 1 means the drug is having a better safety profile. So in this only the glyclazide shows hazard ratio of below 1. So all other drugs have a hazard ratio of either 1 or more than 1, which means they are either no effect or have some adverse cardiovascular outcome. So this is same like the previous graph, which shows that cardiovascular safety of glyclazide and glimepiride, which glyclazide only stands out of all drugs in conferring cardiovascular safety. So apart from preserving the ischemic preconditioning, so glyclazide also has an anti-atherosclerotic action. This is because it helps in increasing the adiponectin levels and decrease the interleukin 6 and TNF alpha, both which are atherogenic. So interleukin 6 at baseline, if it's 3.5, after 12 weeks of treatment with the glyclazide, it's reduced by 1.8. Sorry. And TNF alpha at baseline it was 2.1. After 12 weeks of treatment, it gets reduced to 1.4. And the adiponectin, which was 6.4, helps in 7.6. Glyclazide also has an antiplatelet effect. This is by inhibiting the ADP-induced platelet aggregation. Glyclazide also reduces the plasminogen activator inhibitor levels. What else to say? So this is another graph which shows the cardiovascular mortality between sulphonylureas. So of which glyclazide has the lowest cardiovascular mortality. All other drugs have either very minimal or adverse cardiovascular outcomes. So there's advanced trial which studied about the combined effect of BP lowering and intensive glucose control on macro and microvascular outcomes. Intensive glucose control with glyclazide versus standard glucose control, of which more than 11,000 people were studied. So this study showed that intensive glucose control regimen with glyclazide reduces the both micro and microvascular complications. So the major macrovascular and microvascular complications were reduced. There is a 6% reduction for major macrovascular events, 14% with the microvascular events, and almost 21% reduction in the risk of nephropathy on treatment with glyclazide in comparison to other sulphonylureas. So this is another study which showed that short-term prognosis of microinfarction among use of anti-diabetic drugs. So this study showed that glyclazide is associated with a lower risk of MI than old sulphonylureas like glibenclamide. First generation sulphonylureas and some other few second generation are associated with a higher mortality rate. So this is another graph which comparing the renal outcome in type 2DM treated with different sulphonylureas compared to glyclazide. So glyclazide reduces the incidence of end-stage renal disease and doubling of renal creatinine significantly. So the RSSDI 2020 recommendation for the management of type 2 diabetes, glycoside MR can be preferred over the conventional sulphonylureas in persons at increased risk of CVD or with cerebrovascular disease. So what is the place of sulphonylurea in management of type 2 diabetes? The South Asian Federation of Endocrine Society recommended modern sulphonylureas like glycoside should be preferred in view of reduced CV mortality, better CV outcome, and renal protection. So what are the metabolic and cardiovascular effects of glycoside? On the pancreas, the glycoside helps in reducing the apoptosis, thereby preserving the beta cells, reduce the oxidative stress, and reduce ER stress. All this helps in achieving good glycemic control. And in the kidney, it reduces the oxidative stress, reduce albuminuria, and reduce nephropathy. And in the heart, it helps in improving the ischemic preconditioning. And on the blood vessels, it helps in increase endothelial progenitors, improve endothelial vasodilation, and reduce LDL oxidation. So all this finally results in better CVD outcome. So to summarize, diabetes is associated with the
அவங்க என்ன போச்சு இது இந்த இன்டர்வல்ல வந்து போலாம் போலாம் அது அங்க போய் நான் பேசும்போது இருட்டுல இருப்பேன்னு பார்த்தேன்.
to have established cardiovascular safety. The Gliclazide then cardiac sulphonylurea.
I think Nazir, you can take over.
Yes, a wonderful doctor. மெயினா வந்து ப்ரீகண்டிஷனிங் வந்து இஸ்கிமியா பத்தி தான் அதிகமாக அட்ரஸ் பண்ணணும். இந்த ட்ரக்கை பொறுத்தவரைடைய வேல்யூ அதில் தான் இருக்குது. ஸோ யூ ஹைலைட்டட் தி இம்பார்ட்டன்ஸ் ஆஃப் தி Gliclazide ஃபார் இட்ஸ். ஹலோ, ஐ எம் நாட் ஆடிபிள்.
You are audible. You are audible. You are audible.
And so highlighted the importance of the ischemic precondition as regards the Gliclazide. That is a very important point. That is what now it has attained the much popularity. This drug widely used. I used in a very good number of patients. Definitely, it is a very good presentation, doctor. Well done. Well done.
And just to add on one point, a cheaper drug compared to the newer.
Yes, prices have come down.
Any long-term use should be available and affordable. Affordability is more important. Okay, go ahead.
Correct, Guna. You rightly have pointed out. Sometimes in the என்ன drug select பண்றதுன்னு என்ன drug இவன் தொடர்ந்து சாப்பிடுவான், for fear of the cost he may discontinue treatment and come with complication. So that is very important.
The most important thing is patient compliance in a long-term treatment of hypertension and diabetes, where we have faced several problems.
Yes, we should be very exactly. We should be very careful about prescribing a costly multivitamin along with this anti-diabetic. What happens? That consumes the volume.
The bulk of the volume.
Naturally, what happens? He forgets to, or he hesitates to buy this. So this is all very important.
You can ask the other person to continue. Thank you.
Okay.
Thank you. Nazir question.
Yes. I think it's Nagarajan.
Close பண்ணிட்டேன்.
இல்ல வேலையில இருக்கு காலையில.
Yeah, am I audible, sir?
Yes, please.
நான் இன்னும் பேசணும்.
Okay, fine. Sir, I'm starting my topic, sir.
Welcome, Dr. Nagarajan. Welcome.
Yes, sir. Sir, is the screen visible, sir?
You are visible very much.
Okay. Sir, my topic today is on diabetes and heart failure. I wanted this to be on a black screen because, you know, till now, there is no specific or what is the diabetes or the heart failure. Both are strong contenders for increasing mortality and morbidity in a patient. Each one is entirely a different spectra, and each one can affect the other one and cause significant morbidity and mortality in a patient. So diabetes and heart failure are closely related. Patients with diabetes have an increased risk of developing heart failure, and those with heart failure are at a higher risk of developing diabetes. So the most frequent, forgotten, and often fatal complication of diabetes is heart failure. So patient ending with heart failure. The secular trends in the prevalence of diabetes and heart failure is because of its shared pathophysiology. We can't delineate the pathophysiology of both affecting the heart and other system. And also, we need a synergistic effect of both. We need to weigh the risk-benefit ratio of both to manage a patient. And also the potential newer diabetic therapies to modulate the risk of heart failure outcomes. I think this is well shown by Dr. Mani there. I think the incidence and the prevalence of heart failure and diabetes are increasing. I think, and by 2045, I think 84% in the world will be diabetic, especially in the Southeast Asians. And this is this paper was presented in 2015. It is a retrospective study which showed. Sir, am I audible, sir? Hello? Yeah, yeah. So it's a retrospective study taken by from the NHS by the insurance company, and they evaluated the patients who have come to hospital from 98 to 2010. So they divided into with diabetes and without diabetes, and then they checked out what is the commonest cause. They had visited the hospital and what is the commonest cause for mortality in such a patients. And you see the whole burden of the insurance is being taken away by these two very common things called peripheral artery disease and heart failure. Next comes your angina and other things, stroke, CAD, arrhythmias, etc., etc. So from this point, I think from 2015 onwards, they started giving more importance to heart failure in a patient with diabetes and importance of diabetes in a patient with heart failure. So what is the epidemiology of heart failure? So what is the importance here? Heart failure is twice as common in diabetic men and 5 times more common in a diabetic women. And 12% of type 2 diabetes have established heart failure on presentation. And 3.3% of type 2 diabetes develop heart failure each year. So the trend is more as it is increasing. Once when they develop diabetes, it's always a risk that they can go for heart failure at any time. And moreover, it increases more with elderly diabetics. You see there 1% rise in HbA1c increases 15% risk of heart failure in a diabetic. And finally, mortality in a diabetic heart failure is double than that of a non-diabetic. So is the epidemiology and importance of having this talk. So we always talk about omnious octet in diabetes. And so what are the commonest pathogenesis or pathology in causing a diabetes? But both heart and diabetes share a most common omnious octet like coronary artery disease, cardiomyopathy, autonomic cardiomyopathy, microangiopathy, fluid expansion edemas, renal hyperfiltration, sympathetic nervous overdrive, and hypertension. So once in a heart with heart failure without diabetes or in a diabetic with heart failure, all these 8 things can occur, and further they can go on to cause a recurrent hospitalization and death. So the pathophysiology of progression of diabetes and heart failure is, so you see these 3 things are very important. You see we have hyperglycemia, insulin resistance, and hyperinsulinemia. It can cause inflammation, dyslipidemia, and endothelial dysfunction. A diabetic is an endothelial dysfunction disease, which can cause CAD and ischemic cardiomyopathy, leading on to heart failure. Sometimes these, many a case in a diabetes, when you do an echo, we find concentric hypertrophy. So the patient is not hypertensive, but still, it is related to diabetic and its diastolic valve relaxation abnormalities and hypertrophy here. So these cardiomyocyte hypertrophy in LVH itself can cause cardiomyopathy called diabetic cardiomyopathy. These are the earliest sign of diastolic relaxation abnormality in the heart in a diabetes, can cause heart failure. Third most common is renin-angiotensin activation, causing fibrosis secondary to increased aldosterone and diabetic cardiomyopathy. Abnormal calcium handling because of endoplasmic reticulum calcium handling. A fatty acid utilization. You see, diabetes is an energy-starved pathology here. You see, more of glucose is being converted to fatty acid and ketone body development, which leads to increased fatty acid utilization. And that forms more of superoxidants and formation of advanced glycation end products, which all leads to increased fibrosis and formation of diabetic cardiomyopathy. The fifth one is autonomic dysfunction, which directly leads to diabetic cardiomyopathy and may end up with heart failures. So what are the etiology of heart failure in a diabetic? Most common is diabetic cardiomyopathy. Second, the presence of associated hypertension. Myocardial ischemia, which can be secondary to CAD or microangiopathy or endothelial dysfunction. It's called vasospastic anginas. And activation of renin-angiotensin and sympathetic nervous system activities. Initially, these come into action as a response immediately, but later they all form a chronic disease due to cardiac remodeling, free fatty acid utilization, and induction of fetal gene program, which all leads to fibrosis and cardiomyopathy. You see, this is the survival probability of a heart failure in type 2 diabetes. You see, this is the curve which shows that a patient without diabetes and heart failure, they divided into three: preserved heart failure, a mid-range EF, and a reduced EF. And we see whenever you have diabetes, the mortality is always and survival probability is always on the lesser side than when compared to without diabetes. And those with diabetes and reduced heart failure are at the lowest of the survival probability than others. So whatever you go now, we just need to decide on what is the glycemic goal you want to achieve in a heart failure and a diabetic patient. So they divided into two arms: intense lowering of HbA1c and standard lowering. Intense lowering is to bring it back less than 7, and standard lowering is to bring HbA1c to 7 to 8.4. It is well known that intense lowering will reduce microvascular events like retinopathy, nephropathy, peripheral neuropathy, everything. But there is no effect on all-cause mortality or a cardiovascular mortality and stroke. Even major studies like UKPDS, Advanced Accord, Veterans Association Diabetic Studies all showed no difference in event rates between the intense arm and the standard arm. Fine. So the association between heart failure and HbA1c is consistently U-shaped, with lowest mortality seen in HbA1c between 7 and 8. So all these effects made recent trials to focus on cardiovascular safety of the diabetic drugs rather than concentrating on the potential benefit of lowering the HbA1c targets. So whenever a drug comes to the market, I think this is from 2016 onwards, they started thinking about their cardiovascular safety rather than their glycemic control for that patient. So they have a wide range of HbA1c levels, but most are kept between 7 to 8.5. You see here we have an intermediate life expectancy, stage C or D heart failure patients, and those on LVAD or transplant patients, on oxygen-dependent lung tissues, severe hypoglycemia, advanced cancers. So they form a majority of patients with all comorbidities and all in severe diseases. So it is better to have a HbA1c level between 7 to 8.4 to achieve a good effect of both on the cardiac as well as the diabetic part. When it is more than 8.5, it leads to symptomatic hyperglycemia and all complications occurs in a patient. So management of diabetes and heart failure, cardiovascular safety is important. I think these are some of the trials which showed before. I think which made drugs got stopped because of its cardiovascular outcome. You see, we have rosiglitazone associated with increased risk, and ACCORD studies which shows increased glucose levering was associated with all-cause mortalities. So now we look into some of the effects of the anti-diabetic drugs on heart. What do they do and how do they affect the heart? I think we can do one by one. I think biguanides, they decrease macrovascular endpoints and improve lipid profile. I think metformin is one of the drugs which is being prescribed for a diabetes and a heart failure patient. Sulphonylureas have their effect of increasing weight gain on hypoglycemia. I think Dr. Mani spoke about impaired ischemic preconditioning. I think except for glimepiride and glyclazide, other drugs are strictly to be avoided whenever you use in a patient with heart failure. I think meglitinides have an increased weight gain and increased propensity for hypoglycemia. Glitazones, they increase LDL levels and reduce restenosis after stenosis. Sometimes they can be used, but during a heart failure, it increases the risk of mortality. And DPP4, I think insulin, there is an increased weight gain, increased risk of hypoglycemia, and the death rates and some origin study which classically showed that insulin increases the risk of heart failure in a patient with diabetes. So these are some of the trials, which showed the percentage of risk of heart failure events. Except for, I think this is SGLT2 inhibitors, empiric outcomes, CANVAS, canagliflozin, and this one, what is it? Elixir. This is GLP-1 agonist. All other drugs showed an increased risk for heart failure. So this is DPP4 inhibitors and increases for heart failure. You see, all the one, Savertimi, Examen, Ticos, Carmelina, I think Carmelina is for canagliflozin, saxagliptin, and all those things. They had a very good MACE reduction, almost equal to with the placebo. But hospitalization for heart failure were on the negative side, except for canagliflozin. So now they favor DPP4 inhibitors for heart failure. Sorry, SGLT2. So what is the role of SGLT2 inhibitors in diabetic heart failure? So SGLT2, the sodium glucose transport long chain transport inhibitors, what do they normally do? They on inhibition, they increase the sodium excretion. They increase urinary sodium excretion as well as increased fractional excretion of sodium, and they even slow the renal dysfunction. So this is the potential effect. They bind to sodium hydrogen exchanger. They inhibit, they increase glucosinuriria, increases natriuresis, and sometimes they decrease ketone body production, and they increase reverse remodeling and reduce hypertrophy. So the overall benefit is they improve blood pressure, decreases weight, reduces the risk of heart failure, decreases cardiovascular mortality. So this is with empiric outcome, which shows that with empagliflozin, we see here, so the cardiovascular mortality is reduced, and even heart failure hospitalization was also reduced here. So SGLT2 inhibitors as the first class of OHs demonstrated to reduce the risk of heart failure hospitalization in patients with diabetes. It can be used as a part of prevention strategy in patients with diabetes at high risk for heart failure. So GLP-1, it's a glucagon-like peptide, one drugs like exenatide, liraglutide, lixisenide, semaglutide. So they stimulate glucose-dependent insulin release with a low risk of hypoglycemia. They decrease appetite and increase lipid levels. They decrease triglyceride and increase HDL levels. So other effects are the increased heart rate, they decrease systolic blood pressure, increase renal function. Sometimes they delay gastric emptying and they have increases for cholelithiasis, and they also increase a milder increase in weight loss. So this is a trial called Sustain 6 with the semaglutide, which showed that it reducing heart failure hospitalization. It shows reduced hospitalization, but the impact was not so good. So GLP-1 shows most beneficial effects on cardiovascular outcomes, but no effect on heart failure hospitalization and readmission rates. And this shows the choice of anti-diabetic drug in a heart failure. You see, except for empagliflozin and canagliflozin, I think others are almost on the borderline here for major cardiovascular events. And for heart failure hospitalization, only these two approved. Almost it is safer and also better drug in reducing readmissions for hospitalization and heart failure. So what do the guidelines say? So management of diabetes to reduce heart failure. It's a European Society guidelines in 2019, which shows SGLT2 inhibitors are recommended to lower risk of heart failure patients, hospitalization in patients with diabetes mellitus. This is class 1 recommendation level A. Sometimes metformin can also be considered in patients with heart failure and GFR more than 30, except in cases of acute cardiogenic shock and lactic acidosis. The second drug commonly used is gluconeogenic peptide antagonist. They have a neutral effect on risk of they have a neutral effect on heart failure hospitalization, and may be considered for diabetic patients with heart failure and obesity. So they have mild weight reduction also as their side effect, as their good effect. So the DPP4 inhibitor sitagliptin, linagliptin has neutral effect, and this is the class 2B that indicates it can be used, but based on the weight benefit ratio of the patient and the risk of the disease. The drug to be avoided are thiazolidones like pioglitazone or rosiglitazone, and DPP4 inhibitor saxagliptin is associated with increased risk of hospitalization and is not recommended. These two are class 3 recommendations. So the final summary is diabetes is a growing concern worldwide. Heart failure in diabetes is associated with disturbed calcium homeostasis, mitochondrial dysfunction, and LV dysfunction. Metformin remains the first line of anti-diabetic, and newer therapies like DPP4 and GLP-1 have neutral efficacy, and they can be tried based on the response from the patient as well as the risk-benefit ratio of the patient. And nowadays, SGLT2 is becoming promising among newer anti-diabetics for treating heart failure. ADA 2019 and the ESC guidelines recommend use of SGLT2 inhibitors as the first choice after metformin in heart failure. Thank you. Hello.
Am I audible?
Yes, sir. So any questions, sir?
I think they have not unmuted the other mics. They have to unmute all other mics.
Yes, sir. I think
they have not yet done it.
Hello.
Only you are audible.
The company people should do it, sir, because when the speaker speaks, others should unmute. The admin should do it. I don't know.
No problem.
Agarwal, you should do this, or Mithun Thakur.
Hello.
It's your duty. Please do it.
Unmute.
Guna?
Yeah, I'm audible.
Yeah. I'm audible, huh?
Yes, sir.
Yeah, I'm audible.
Okay, Nagarajan.
Yes, sir.
SGLT2 regarding that, one thing must have been mentioned is the
amputation and
euglycemic ketoacidosis.
Yeah, the three side effects are euglycemic ketoacidosis, sir, and fractures and toe amputations are common, sir. And so I think not common, it is at a higher risk, sir. Yeah. So that only canagliflozin was withheld
Preferable.
After canvas studies.
Okay. Right. Then the opportunistic infection is very common. That
yes, genital infections are more common, sir, actually.
Okay.
Because it's it acts via kidneys, sir. So genital infections are more common there.
Any point to be added, Guna?
Nothing. That's a highly
specialized. Okay, we'll permit
subject.
the next person.
Yeah.
Doctor from Kangayam, welcome.
Dr. Magadeswaran.
Magadeswaran. Doctor.
I know. Yeah, his video, his screen is being scared.
Sir, please unmute, sir. You are not audible.
The company people could do that.
Congratulations, sir. You are not audible.
Not visible also.
Mithun Thakur, please unmute Dr. Magadeswaran, sir. Aditya Agarwal.
Good evening to all.
Welcome. Video, your video is.
Proceed, doctor, proceed.
Yeah. Good evening to all. Am I audible?
Yes, yes.
Yeah, you're audible. Video. Your video is.
Today's last topic. Diabetes management of diabetes in chronic kidney disease. The prevalence of diabetes across the world has epidemic proportions. It is estimated to affect 9.3% of global population. More than 40% of people with diabetes will likely develop chronic kidney disease, including a significant number who will develop end-stage renal disease requiring hemodialysis and renal transplantation. Diabetes is the most common cause of chronic kidney disease. Around 31% of CKD is due to diabetes. Diabetic kidney disease is defined by persistent proteinuria more than 30 milligram per gram of creatinine in spot sample, or low GFR less than 60, or both for more than 3 months. Diabetic population with kidney disease has a heterogeneous renal involvement. Classical diabetic nephropathy is a cause of CKD only in 20 to 40% of patients. There is a high prevalence of non-diabetic renal disease. After renal biopsy, almost 2/3 of the patients will have non-diabetic kidney disease. The most common causes are hypertension, atherosclerotic renal artery stenosis causing ischemic nephropathy, glomerular diseases, tubulointerstitial diseases, and drugs like ACE inhibitors, NSAIDs, and ARBs. Regarding pathophysiology, chronic hyperglycemia causes metabolic and hemodynamic alterations within the glomeruli, which results advanced glycation end products and local renin-angiotensin-aldosterone system activation, which causes inflammatory mediators activation and activation of cell signaling pathways and transcription factors, which causes structural alterations within the kidney. The pathological changes includes basement membrane thickening, extracellular matrix deposition, mesangial expansion, podocyte alteration, followed by glomerulosclerosis, interstitial inflammation, and fibrosis. In natural history of diabetic kidney disease, the end-stage renal disease usually develops 20 to 40 years after the diagnosis of diabetes mellitus. There are 5 stages in the natural history, starting from hyperfiltration, silent phase, which structural changes, followed by microalbuminuria, then macroalbuminuria, rising creatinine, and end-stage renal disease. In the UKPDS study, 15 years after the diagnosis, 40% of patients had a macroalbuminuria, and 30% had an low EGFR or doubling of serum creatinine. Goals in the management includes glycemic control with HbA1c target less than 7%, blood pressure control with less than 130/80 if proteinuria reduction with ACE inhibitor with or ARB, dyslipidemia with statins, smoking cessation, restriction of protein intake less than 0.8 grams per kilogram per day, and weight reduction. Lowering HbA1c less than 7% reduces the development of diabetic kidney disease and microalbuminuria in DCCT EDIC trial over a period of 7 to 8 years follow-up. For glycemic control, along with lifestyle therapy, metformin and SGLT2 inhibitors are the first-line drugs recommended in diabetic kidney disease. The other options includes GLP-1 receptor agonist, DPP-4 inhibitors, insulin, sulphonylurea, and pioglitazone. Treatment of diabetic kidney disease has been expanded from glucose-centric concept to an event-driven strategy due to high prevalence of CV and renal complications. Among these agents, only metformin, SGLT2 inhibitors, and certain GLP-1 receptor agonists have shown to improve renal and CV outcomes regardless of glycemic control. KDIGO 2019 guidelines recommends metformin as a first-line treatment of diabetes with CKD with EGFR more than 30. Metformin has a renal protective mechanisms by increasing adenosine monophosphate activated protein kinase and increased GLP-1 levels, which causes reduced inflammation and reduced oxidative stress within the kidneys. If EGFR less than 45, metformin should be initiated at a half dose and can be titrated to half of maximum recommended dose, and vitamin B12 should be monitored if metformin used more than 5 years, and renal function should be monitored annually. After metformin, SGLT2 inhibitor is the preferred OHA in diabetic patients with CKD. Based on various trials, KDIGO 2019 recommends SGLT2 inhibitors if EGFR more than 30. SGLT2 receptor is a major transport protein and mainly expressed in epithelial cells of the proximal tubule. It increases the glucose urea, and it increases the diuresis and natriuresis. By increasing glucose urea, it reduces the glomerular hyperfiltration and reduces the intraglomerular inflammation and fibrosis. That's why preventing the CKD progression. Additional benefits includes it reduces the risk of heart failure, it reduces the blood pressure, it reduces the body weight, increases the lipolysis, and it improves the fatty liver also. In natural history of diabetic kidney disease, glomerular hyperfiltration is the early stage. SGLT2 inhibitors reduces the glomerular hyperfiltration and it prevents the progression of diabetic renal disease at early stage itself. Meta-analysis of 38,723 participants among various studies showed SGLT2 inhibitors products loss of kidney function, end-stage renal disease, and death due to diabetic kidney disease. In EMPA-RED outcome trial, studied more than 7,000 people with type 2 diabetes and established CV disease over a period of 3.1 years. There is a 39% risk reduction of new onset or worsening nephropathy, and 44% risk reduction of doubling of serum creatinine, and 55% risk reduction of initiation of renal replacement therapy. In CANVAS trial, canagliflozin reduces the renal events from 0.9 to 0.6%, but it increases the risk of amputations, fractures, genital infections, and dehydration. Credence trial favors the canagliflozin use and in diabetic kidney disease. DECLARE-TIMI-58 trial shows dapagliflozin reduces the overall composite renal outcome by 24%. Credence, DECLARE-TIMI-58, Canvas, and EMPA outcome all trials favors SGLT2 inhibitors in prevention of kidney failure in patients with diabetic kidney disease. In patients with type 2 diabetes and CKD who have not achieved HbA1c target with metformin and SGLT2 inhibitors and who are unable to use these medications, KDIGO 2019 recommends another new drugs, GLP-1 receptor agonists. GLP-1 receptor agonist improves renal and CV outcomes in diabetic kidney disease. Additional benefits includes it increases the satiety and promotes weight loss. The exact renoprotective effect have yet to be established. Proposed mechanism includes inhibition of sodium hydrogen exchanger in proximal tubule. It promotes natriuresis, diuresis, BP reduction, and reduction of albuminuria. A recent meta-analysis of various trials confirms GLP-1 receptor agonists were associated with 17% relative risk reduction in a broad renal composite outcome over a period of 3.2 years. The renal benefit was almost entirely driven by reduction of urine albumin excretion and not by hard renal endpoints such as decline in eGFR, end-stage renal disease, or kidney-related death. In various GLP-1 receptor agonists, dulaglutide, injectable semaglutide, and extended exenatide can be given at weekly doses. Leaders trial for liraglutide, Sustain 6 trial for semaglutide, and Excel trial for exenatide reduces the composite renal endpoint by the reduction of new onset macroalbuminuria. However, evidence of direct benefit on hard renal outcome is still lacking. Regarding DPP-4 inhibitors, saxagliptin and linagliptin can be used up to GFR 15, but SAVOR-TIMI trial, saxagliptin reduces the albuminuria, and Carmelina trial, linagliptin reduces the albuminuria, but there is no difference in renal outcomes. Summary. Long-standing diabetes often progresses to CKD. Use of newer anti-diabetics like SGLT2 inhibitors arrest CKD progression by reducing the glomerular hyperfiltration, and SGLT2 use in diabetic CKD patients is endorsed by ADA 2019 and KDIGO 2019 guidelines. GLP-1 receptor agonist reduces albuminuria and CKD progression, and it can be used even in low GFR state. Dose adjustment is necessary with other anti-diabetics according to eGFR to avoid hypoglycemia in diabetic CKD patients. Thank you.
Yes, please, Muna.
No, I think it's a very highly specific discussion. But my only thing was, how will we know that SGLT2 inhibitors can be used in nephropathies? Because it takes about 15 to 20 years for someone to develop well-controlled diabetics, CKD. So SGLT2 inhibitors are available for, say, past 5-6 years. I'm not very familiar. I've not been using it.
3 years.
So I think they should be able to say how, say, they said it prevents dialysis patients going in for transplant. I don't know. You should be, because a cheaper drug like metformin can do all this, and you should be able to tell us, and you should enlighten the people who you see more diabetic patients than me. I think you can start the discussion better.
In cardiovascular point, the SGLT2 is definitely more beneficial. But as Dr. Guna asked the question about the renal aspect, but I'm also not very confident about that. I think it is always useful in congestive heart failure. Almost it has become a non-diabetic drug nowadays, more used in, like Nagarajan will tell me. Yes, Nagarajan.
Sir, I think the renal safety, what Sir has said, is almost a good, sir, actually, because the recent trials on SGLT2 inhibitors have very clearly shown. But the last trial, the total population they choose was around 6,000 or 7,000. So that very clearly says that we can use it, sir. Since the drug is almost less than our 3 to 4 years in the market, we need some large data still more to extrapolate on for renal issues. For cardiac wise, I think both for cardiovascular safety and heart failure prevention, SGLT2 inhibitors are much better drugs.
Definitely,
Among
now
that
it has been taken out of patency, the prices also come down to
Yes, the prices also will be coming down.
That is a very good advantage. Yes, that is another advantage.
So the whole thing was a very useful webinar. Wish we could have met personally. Anything else? Any audience questions?
Sir, this webinar, no, sir, I started preparing for this webinar 3 days back. But I could get a bunch of articles about the newer drugs, newer SGLT2 trials on heart failure and hypertension also. So I think our latest books will get them updated. It's a very useful drug. It has you see the effects and the trends they have taken in coming into market and now capturing almost half of a diabetic population with hypertension, CAD, renal involvement. I think after metformin, SGLT is going to be the next metformin, I suppose, for the next 5 to 10 years.
But it's very useful. Otherwise, so one thing is, our doctors community should understand either the participant or one of their family members. Mostly, you see so many diabetes, hypertension, such a common illness. We should be thorough in all aspects, and we should be able to select the appropriate drug and prevent, make the best use benefits of all the latest drugs. So in such aspect, and I congratulate Dr. Ishramurthy for coming forward to enlighten this using his team. Well done, Dr. Ishram.
I think we need to discuss more on common topics, like
very frequently,
obesity, because obesity is all now becoming a pandemic, sir. We just need to, because I think 5 in 1 patient is almost obese.
You ask Nagarajan, any patient, when did you walk 3 kilometers? I don't think 10% of the patients with diabetes, hypertension, they've never walked. They don't even walk 3 kilometers. Not even 3 times a week. If you go on the road walking, you see only people who have been walking. You don't see any newer diabetes. They'll say, give me some drug, sir, that will reduce weight. Give me some drug that can reduce my sugar, reduce my BP. Don't talk about lifestyle changes.
Lifestyle changes,
Yes. Very, very difficult. Very difficult to convince patient about exercise, the benefits of exercise.
And many a time I see diabetologists writing at least 6 drugs, sir, all in one group. I think many diabetologists, if there, I can always let them share their views also. My patients, when they go out, and I usually tell them, you consult your diabetologist for your sugar control. When they come up after 3 to 4 months, they are put at least on 4 groups of drugs. You start on a drug, you see, if you start a true drug, you just wait, you see how it responds, and then you can increase your dose or increase the change over to another drug. But starting on our 3 different drugs, I don't know how it is. And with that, they will have a basal insulin also. I don't know. There is no, like hypertension guidelines, we need something for practitioners, to start with what to do, what not to do. Putting 6 drugs are diabetic, that itself makes them poorly compliant. They won't be able to take, I suppose, even after 3 months. with at least 2 vitamins. I don't know what those vitamins are going to do. Sir, any suggestions, sir? Anything? Magdeshwar sir, you can talk on, because you are good practicing, I would say, sir, your views, sir, on diabetic drugs.
Sir, I'll use metformin as an initial therapy.
Yes, sir.
After metformin, I'll go for DPP-4 inhibitor or SGLT2 inhibitor.
Yes, sir.
In sulphonylurea, I'll select Gliclazide if needed.
Okay. So, role of those acarbose and all those drugs, sir? Goglibose, acarbose. For reducing, initially it was started for postprandial hyperglycemia, I suppose.
Narayan,
yes, sir.
Such drugs, already the diabetic people will be suffering from gastroparesis.
Yes, sir. Yes, sir.
You add some more fuel to the fire, and they will come with severe bloating, and they are always complaining about the acarbose. Very difficult. Practically, you ask the patient who is taking, it's really very difficult, because we know gastroparesis go along with the diabetes, no?
Autonomic neuropathy. Autonomic.
Diabetic gastroparesis, அது வந்து வேணா தியரிட்டிக்கலா இருக்கலாம், ப்ராக்டிக்கலா எனக்கு நான் என்னோட பேஷண்ட்ஸுக்கு ரொம்ப அந்த கம்ப்ளைண்ட் கேட்பேன். ஐ ஆஸ்க் வெதர் ஏதாவது அவங்களுக்கு இந்த மாதிரி ஆல்ரெடி ஜிஆர்டி ஏதாவது இருக்குதா, இந்த மாதிரி ஏதாவது லோஸ் எல்இஎஸ் லாக்ஸிட்டியோட இருக்கு, சஃபர் பண்றாங்களா, ரொம்ப ஸ்பைசி ஃபுட் சாப்பிட்றாங்களா, ஏர்லியா பெட்டுக்கு போறாங்களா தெரிஞ்சுக்கிட்டு தென் ஐ வில் ask them to take the drug during lunch time, so that at least they will not lie down and they will suffer more. It's not the practical things.
I think recent European guidelines specifically says for heart failure and diabetes, if not getting controlled, either glycemic or heart failure, you kindly consult an endocrinologist. That is the last point they mentioned. Because diabetics and heart failure, it is a tricky situation. So we just can't wait for one or the other to flare up. They wanted an endocrinologist also to see it, so that your drugs for diabetes shouldn't affect your heart failure, or it per se itself can cause heart failures. I think any diabetologist here, sir, I think they would be actually, because we have many questions here for this, diabetes and cardiac. So when they come with CAD or ACS, we give them insulin. They go for post-MI failure, and we think we treat them, we discharge them on drugs. They are put on insulin, and when they come after 3rd month, the 4th month with the dyspnea, we just need to, because all patients, I think it's a new trend now, all diabetologists are starting with a basal insulin at night. So insulin heart failure itself is a very good topic, sir. Actually, insulin increases heart failure risk.
Anything more?
Thank you, Nazir. Thank you, Nagarajan, Magadeshwaran, Mani, for tightening and bringing back something about diabetes, especially like me. All I could remember is nephrons and neurons are not post-mitotic. They don't divide, so they are same. Once lost forever.
Always last.
Always last. So try to protect them. That's the first thing. Try to protect.
When neuron is lost, everything is lost.
You be happy. You be happy. Don't bother about anything. Don't bother your creatinine is 4 or 5. Be happy.
So I was before we leave, I will dedicate 4 lines of song to Guna.
Okay.
Just listen.
Please.
Okay.
Please. Okay.
உச்சந்தல உச்சியில உள்ளிருக்கும் புத்தியில ஃபால்ட், அப்பர் மோட்டா நூறனுல ஆண்டவனா பார்த்து வச்ச வேட்டு, எப்படி தான் வந்ததுன்னு கேட்கறது யாரு, தப்பு இருந்தா என்னதுல எம்ஜிஎஸ் கேளுன்னு முடிச்சுக்கலாம்.
Oh, thank you very much. Thank you. Thanks
Just
for the nice
let us go with some fun. Okay.
Yes, sir.
Okay.
Yes, sir.
Thank you, Nazir. Thank you, Narayan. Bye, bye, bye.
Thank you, sir. Thank you.
Okay, bye, bye.
Magadeswaran sir and Mani.
Thank you, sir.
Thank you, Tirupur.
Thank you, sir. Thank you, sir. Thank you, all doctors, for your participation. Thank you so much.
Thank you. Thank you.
Thank you.
Bye, bye.
Bye, bye.
Thank you.
Thank you, sir. We are closing, sir.
Okay,
Yes, sir.
close.
Good night, sir. Good
Good night.
Great, okay.
Good night, sir. எத்தனை பேரு அவனுக்கு